A hearty good afternoon, everyone, and welcome to our session on hysteroscopy in infertility. Now, we are glad to have Dr. Alekya Reddy among us today to help us understand the topic. A hysteroscopy before an IVF treatment is a must, as it is the best way to check if your uterus is healthy and ready to carry a baby. But why is it important for someone facing infertility? The doctor will guide us on the same. So, doctor, you have the stage.
Okay, thank you. Yeah. Hi, this is Dr. Alekya Reddy. I'm a fertility consultant at Apollo Fertility Banjara Hills. And this is one of the most frequently asked questions that do we need hysteroscopy before any fertility treatment, before IUI or IVF? So I just thought we'll discuss a few points over hysteroscopy and then you'll get a clarity. And again, if you have any questions, feel free to ask. We are here to help you. Right. So, what exactly is hysteroscopy? It's basically a procedure which is used to visualize the uterine cavity through a device which looks like a telescope, through a device known as hysteroscope. These days, it is a gold standard method for investigating the uterine cavity, particularly when any pathology is suspected. So, pathology could be suspected while doing a scan or while doing HSG, that is histosalpingograph. Um, and because of the direct visualization, this is more clear, and that's why it is known as the gold standard method these days. Okay, so it is a safe test for the direct and accurate diagnosis of any intrauterine abnormalities. And again, it will again allow us for correction of several pathologies if we see then and there, right? So, when is it performed, which is a most commonly asked question. So, usually we do it after the day 6. Between day 6 to day 13 is the best time, we believe, when it's more post menstrual. This is the post menstrual phase. It can be done under anesthesia or without anesthesia also, which is known as office hysteroscopy, which is commonly performed these days, where we give just a local sedation and some painkillers so that the patient is comfortable and we can go ahead. The distension for the uterine cavity is normally used is normal saline, or some people also use 5% dextrose in water. Some people use glycine. In the past, some people used to use CO2 as well, but then these days, because it is easy and then it is less traumatic and doesn't give a lot of allergic reaction, so we use normal saline for the distension. What else would we use? So this is usually a optic hysteroscope or resectoscope. This could be rigid or flexible, and hand instruments like scissors, graspers, and biopsy forceps is used. Camera light, light cable, and monitor. These are the things used in hysteroscope. All right. So right now, what are the most common pathologies seen inside, or what is the indication for the hysteroscopy? All right. So if you have any intracavity pathology, for example, submucous fibroids, or endometrial polyps, or any uterine septum which is seen, or any intrauterine adhesion seen. The others could be like a failed IVF or failed recurrent implantation failure, or any proximal tubal occlusions, chronic endometritis, or hydrosalpinx, right? So let's discuss each, like what would be the treatment and would we need any hysteroscopic procedure if we come across any of these. So when it comes to fibroids, that is a submucous fibroid, usually if it's distorting the uterine cavity, then that can result in difficulty in conceiving, or that could also increase the risk of miscarriage. In those cases, we do the hysteroscopic management. Usually it is supposed to be within the endometrial cavity, or the extension into myometrium should be less than 50%. So we can do the hysteroscopic removal of the fibroids in such cases. Secondly, um, very commonly seen phenomenon is endometrial polyp. So it is most commonly found in the intra cavity findings, and is the most common finding on the scan. And polyp can It may be related to the mechanical interference with the sperm transportation, which is a little rare, or a space occupying lesion interfering with the embryo implantation, which is very common. Even if the polyp, even if we see the polyp on the first go, we usually give a few months for them to try naturally. And again, if they are not able to conceive, if there are multiple polyps more than 5 mm, and there's a huge mass, then we better remove it on the first go. But then if it's just one polyp less than 5 mm, and we feel that it's not exactly at the implantation point, then maybe we can wait for a few months for them to try naturally, and then go ahead with the hysteroscopy for the polyp removal, which is the most common procedure done these days. All right. Then the other intrauterine pathology would be a uterine septum. So earlier they would always go for laparoscopy, but these days, luckily, we can do the removal via hysteroscopy. Again, that can interfere with the implantation, and that can increase the risk of the miscarriage. And because it's an anomaly, the correction is very important, especially in case of multiple miscarriages, recurrent pregnancy failure, or implantation failure, then we must do it. And the incision of the septum can be done using cold scissors or unipolar, bipolar cautery, or laser septum, or other. And these days, even the hysteroscopic metroplasty is done. The advantages over the laparoscopy is there won't be any abdominal incision, there won't be any myometrial incision. It's an outpatient procedure. You don't require a cesarean post this, and there is no post-op morbidity, very less post-op morbidity, quicker recovery, and no surgical induced pelvic adhesions because of hysteroscopic metroplasty. The other important factor where we would like to do an operative procedure would be any uterine synecdoche. Uterine synecdoche, also the Asherman syndrome, where there are dense adhesions formed between anterior and posterior wall. This could be due to any trauma, for example, any curate done in the past, or due to infection. So in these cases also, we need to remove the adhesions, and hysteroscopy would be one of the best thing uh, to be done, right? And now the complications related to the hysteroscopy, it could be intraoperative or postoperative. So intraoperative, but the incidence is very less in both the ways. In both the in perioperative and postoperative, the complication rate is very less. Usually, incidence is only 0.2%. 10% of the major OP surgery or major surgeries might have it. Perioperative, it could be due to any anesthesia, allergic reaction, or CVS, due to position in the lithotomy position, if there is any nerve compression or something like that, or access to the interpental cavity, or the cervical trauma, uterine perforation, could be a gas emboli, or bleeding, or injuries during the procedure. Now, post-operative is most commonly either the infection or the bleed, and both can be controlled. If you give a good course of antibiotic, infection is very rare, and bleed can also be controlled. And very rarely intrauterine adhesions. The incidence is very less in that. All right. So this is it about the hysteroscopy, and then not necessarily that everyone trying for fertility treatment needs to go for a hysteroscopy. Only if you had multiple implantation, like in IVF, if you had multiple implantation failure, then maybe like a diagnostic, you can go inside and then see, because it's a direct visualization, and we can see the uterine cavity, anterior wall, posterior wall, lateral walls, if everything is fine, if there is any polyp, or if it's polypoidal, or if there is any cynic, then we can do. And also a gentle curate can increase the blood supply, and then it can increase the chances of implantation in the future. So that is one of the most common. And in general, yeah, if you see any polyps or fibroids, then you can think of going ahead with hysteroscopy, not necessarily always. Then most commonly asked question is, if we can see these things in HSG, then why should we go for a hysteroscopy? So again, in HSG, first of all, there is no direct visualization. We are sending in a dye, so the chances of complications are more because of the dye, and sometimes maybe you won't be able to see the exact. You can check the tubes properly, but not exactly the uterine cavity can be assessed. So in hysteroscopy, because it's directly under camera, so you can have a better view, and then you can correct it better in a better way. Also, it is like in HSG, it could be just diagnosis. In hysteroscopy, it's going to be diagnostic plus operative. Like if you find a problem, then and there we can find a solution and we can repair it. Yeah. And in hi yes, and yes, in case of laparoscopy also, along with laparoscopy, because this would be a small procedure, we can go ahead with hysteroscopy, check the uterine cavity, and also we can do tube testing along with saline sonography. So again, that would be a wholesome test where you are checking the cavity, you are checking the tubes, and everything is clear. Yeah. Also, it was a short topic, so we didn't have much to speak about it, but because it was commonly asked, so I wanted to ask you, and you can go ahead with any questions if you have, so that, all right. Yeah, I don't think there are many questions right now, but if you have any questions, feel free to note down and then ask us on the video, and we shall get back to you with the answers. If you are viewing it, then you can ask them now. Yeah, most commonly questions, yes. If it's safe, yes, it's a safe technique. Uh, as I told you, the complications are very less. So, yeah. And someone had asked that if a pre IVF hysteroscopy is required for everyone. My answer is no, because on the scan, if we find any abnormality, then only we're gonna go for a pre IVF hysteroscopy. But again, if they had multiple IVF failures, then it's better we view it under the camera, the uterine cavity, and see if everything is fine, and then place the embryos. That could be one of the things. Uh, if diagnostic hysteroscopy is required, although all no, if everything is normal in HSG, then it is not required. As I told you, only if we see any pathology, then we are going ahead, or if you have any recurrent failures, it could be recurrent pregnancy loss, it could be any recurrent implantation failures, or it could be any IVF failure, and a persistent infertility, even if she's ovulating well, her tubes are fine. And if the sperm count is good and all of that is good, so just to rule out other abnormalities, we need to do the hysteroscopy, but it's not a compulsion. Yeah. Yes, it is very cost effective also. If uh, and then again, you have the option of office and office hysteroscopy without anesthesia. So the anesthesia complications also come down that way. But it depends on patient to patient and the bearing capacity. All right. Okay, then it was nice talking to you all. And if you have any questions, just let us know. Right now, I'm signing off. Hope to see you soon. Bye bye.